March, and we're already starting our revision, which is good. So it's probably more of a introduction to neonatology rather than a revision lecture, but we'll see. I've added some I started with not so many EMQs. I've added a couple into just for fun. So if you put your hand up if you're doing peds at the moment. Okay, so there are a few people. I'll try and remember you so I can quiz you. So peds is great, and neonatology is brilliant, and so it's a good sort of appropriate place to start the year because you get to hang out with lots of cute babies. So I'm going to spend a minute with some random tips for fourth year, and then we're going to sort of go pretty logically, start out at the transition from in utero to extrauterine life, talk about what a normal newborn, how they're normally cared for, neonatal screening and vaccinations, how to examine a newborn, resus, prematurity, and then a couple of specific presentations, respiratory distress and neonatal jaundice. My name's Eddie. I'm a final year. I'm at the Alfred, so if you're around, do say hi. I did a BMed-Sci last year in pancreas physiology, and I'd very highly recommend a BMed-Sci if that's something you're considering. And you can chuck me a question by email if you have any questions now or afterwards. So I think it's a great idea to start with a study group now. One of the things that really got me through fourth year, both sort of academically and emotionally, was my study group. We met sort of once a week at someone's house, and all throughout the year, because then the advantage is you turn up to each of the subsequent rotations with some idea of how the previous rotations have gone. So you can turn up to your second rotation with some knowledge of words that aren't familiar to you. You'll notice there will be some words that I'll talk about tonight that you'll sort of think, I've got no idea what that is, because it's a very sort of ped-specific word, and even just being familiar with terms like tocolytics and preeclampsia and Meconium and random things like that you might not have encountered if you've done psych and GP, but that are very important in women's and peds. And so that's what I mean by fill in the gaps. It helps you get an idea of what your friends in different rotations are doing, and I just found it really valuable all the way through fourth year. Get your hands on resources now while it's early, so that you don't have to worry about that later. In terms of paediatrics specifically, there's a set of, Rupert Hines is a gastroenterologist at Monash who, from his tutes, there's a set of notes that someone made. If you can get your hands on a copy of those notes, that they're really good. I've just chatted to Dinesh, and I'll pass on Tom Liu, who's a couple of years older. He did some peds lectures when I was in fourth year on those topics, and he was great, so I'll pass it on to Dinesh, so you should have a listen to those. In terms of OSCEs, you really need to think about sort of the MERTAR approach, which those of you in GP will have learned, and that's thinking about what's common and what you don't want to miss. We had or I have heard of an OSCE once at a university somewhere where there was hematuria and sugar in the urine, and the person had bladder cancer. And it's not a common thing, but it's something you don't want to miss. And I didn't say, the hypothetical person who told me about the hypothetical OSCE didn't say that there was a bladder cancer, but they did do a cystoscopy, and then they wouldn't have missed the bladder cancer, hypothetically. So it's really about thinking about what you're not missing and what's common. They're the most important things. And do a BMed-Sci, because it's really great. And if you want to chat to me about it afterwards, feel free to. Also, Karen and Sarah, who are 2 final years, have just started a podcast. And if you like kind of quirky ways of remembering things, they tell lots of stories. You'll have a listen. It's called Humorous Hacks. So yeah, the transition from intrauterine to extrauterine life is pretty amazing. And you'll find probably when you do ONG, or if you have a cesarean list as a ped, it's a pretty awesome experience, just because everything about it is pretty amazing. So if we start with the circulation, because that's kind of sort of relates very closely to the respiration, is that you start. So you start with a circulation that's coming from the placenta, emptying into the IVC, the inferior vena cava. And I like this diagram because it shows where you've got your oxygenated blood and deoxygenated blood, which is obviously opposite to normal. Then you have here what's called the foramen ovale, and here what's called the ductus arteriosus. And it's those two things that allow the oxygenated blood to get into basically to bypass the lungs and get into the left side of the heart and then get to the systemic circulation. So, and I think being able to visualize that the foramen ovale is between the atria and the ductus arteriosus is between the pulmonary artery and the aorta here is a really important way to start thinking about the transition of the circulation. So in a fetus, the lungs are filled with fluid, and that means you've got a high pulmonary vascular resistance. So out of the right side of the heart, not much blood is coming, and that's because we want it. There's no use to us as a fetus for blood going to the lungs. We want the blood to all go straight, as much of it as possible, to go straight from the placenta to the systemic circulation. So it's good to have high pulmonary vascular resistance. Additionally, there's low placental resistance and a low systemic vascular resistance, and that's so that the placenta can get up to 40% of the blood flow. So most of the blood is trying to go to the placenta so that you can get that oxygenated blood. As I mentioned, there are 2 right to left shunts, and that is what allows us to get oxygenated blood to the systemic circulation. Also, it's important to note that a fetus needs much less oxygen than a baby does because they don't have to do things like thermoregulate. They don't have to do things like breathe. They don't have to digest. All that stuff is done by the mum, and so they actually need much less oxygen as an in utero than extrauterally. So when they transition to being extrauterine, being a neonate rather than a fetus, they ideally will get alveolar fluid clearance, so they'll clear the fluid from their lungs, and often that's assisted by the compression of contractions coming through in a normal vaginal birth. That leads to lung expansion, surfactant release, and that, as the lungs expand, creates a massive, massive decrease in the pulmonary resistance. So what that means is now instead of there being basically a block on the pulmonary side, forcing the circulation to go around the systemic circulation, we now get a massive decrease in the pulmonary resistance, and so the blood suddenly can flow through the pulmonary circulation. And that's good because it means that we can now get our oxygen from breathing, and it also means that those 2, certainly the foramen ovale, but eventually the ductus arteriosus can start to shut as well, and that's the change that happens when you go from intra to extrauterine. Additionally, when you remove the placenta, the systemic blood pressure goes up because you haven't got this low resistance, sort of very easy passage to the placenta that's there anymore. You've just got a nice resistant clamped umbilicus. And I guess the only problem can be then if those lungs don't expand properly and you get some pulmonary hypertension or anything that's preventing the flow into the out of the right side of the heart, those shunts don't shut, and that's when you get a PDA. In terms of respiration, the majority of the fluid in your lungs is squeezed out in childbirth, and ideally the lungs will fill with air straight away and surfactants produced. Now, if you don't have any, don't have any surfactant, such as if perhaps it's a premature baby, then that can lead to what's called respiratory distress syndrome, which we'll get to later. Alternatively, if you get the opposite, instead of getting no surfactant, you just get retained amniotic fluid in the lungs, then that can cause transient tachypnea of the newborn, and the risk factor for that is a cesarean because you don't have that squeezing process as the baby comes through the vagina during a normal vaginal birth. And you can just use oxygen to try and help get rid of that fluid. So we've got a transition in terms of the breathing, we've got the circulation flowing completely differently in our neonate, and we've also got differences in terms of temperature, metabolism, and fluid balance. So obviously a fetus doesn't need to do thermoregulation, and now this kind of naked, unable to fend for itself, large surface area to volume ratio, because it's a small thing, think about cells in first year, means that newborns cool very, very quickly. And so it's very important to use warm blankets, use what's called a humidity crib, which you'll see if you do a Caesar list or a neonate ward, which is just like a heated crib, and to make sure that they're kept warm because they won't necessarily be used to that straight away. Also, the hormones in the newborn take a while to kick in, to go from because many of those hormones are produced by the mum, and the bub now needs to start producing the hormones itself. And because they take a little while to kick in, you can get a hypoglycemic presentation in the first couple of hours as those hormones kick in. So that's something you need to think about, especially if the mother's diabetic or if one of these other things means that the hormonal balance in the bub is abnormal. Also, it's important to just because of basically the baby starting to do its own fluid balance, a lot of that's done very differently in the amniotic fluid than it is done in air, and so the kidneys have to change how they're working. And so what that means is the fetus loses a lot of sodium and a lot of fluid generally over those first couple of days, and that's normal initial weight loss as the kidneys start doing their thing. In terms of the gastrointestinal tract, at the top, the neonate should start suckling and swallowing. I mean, hopefully you'll see when you do ultrasounds that it's suckling and swallowing as a fetus as well, so it should be already doing those things. But that tends to start around 34 to 36 weeks, and so if you've got a super premature or a late bloomer, then they might not be doing that, and that's obviously got very important consequences. A healthy term baby's demands to be fed 8 times a day or more, so it's important to give that context to the mums. And here's one of those fun peds words, a meconium, which just means the first stool to be passed, which in terms of obstetrics is often a sign of fetal, or often interpreted as a sign of fetal distress, just because it means that the fetus is at higher risk of being distressed. If you see the meconium passed or meconium stained PV amniotic fluid, or liquor is the word I was looking for. But if the baby doesn't pass the meconium in the first 48 hours after birth, it's almost always pathological, be it a meconium plug, a meconium ileus, which can be caused by cystic fibrosis, or Hirschsprung's disease. Hirschsprung's disease is a genetic disease where you get sort of denervation of the distal colon, as you can see here, and what that leads to is basically bowel obstruction, which needs to be rectified by surgery, sort of fairly importantly and quickly, so that the fetus, especially if it's that early, it can present later on, say in early childhood with small, hard, pellet-type poos as well, but often it presents as failure to pass meconium. So looking out for that meconium is always an important thing to do with a neonate. Also, vitamin K is only produced once the bacteria colonise the gut, which only happens once the baby's born. Often those bacteria come from the vaginal flora, otherwise they come from the world around them, but they don't have them in the hopefully sterile amniotic sac, and so only that vitamin K is going to be produced then. And so in order to prevent what's called hemorrhagic disease in the newborn, we give all newborns a vitamin K injection to enable them to start making those clotting factors a bit earlier. So what puts someone at risk of having difficulty with any of these things? And the reason that I'm mentioning this is because these factors, as you'll find when you do either obstetrics or paediatrics, these factors are the factors that put you at risk for a lot of the pathology. So they're factors that are worth learning, and it's worth having a list that you can riddle off, because it is a common OSCE station of like, what are the risk factors for X? What are the risk factors for prematurity? What are the risk factors for gestational diabetes, preeclampsia, placenta previa? And a lot of them will overlap, which is why I thought I'd give you this as an example, even though it's a little bit of an overlap between, I mean, neonatology is an overlap between obs and peds, but yeah, that's why I thought I'd talk about this for a minute. So it's important to remember that 90% of neonates succeed with no intervention whatsoever, from being a fetus to being a neonate without any issues. And then about 9% who need some help, be it a bit of stimulation, a bit of warmth, a bit of phototherapy, a bit of oxygen, and then only about 1% of births need serious resuscitation. So the factors, it's also a good way to break them down in terms of maternal factors and fetal factors, and then sort of delivery complications, and in this case we've also got some antepartum complications as well, but they kind of fit under maternal factors as well, depending on how you classify them. So the older the mother is, if they've got diabetes or gestational diabetes or hypertension, substance abuse, a history of stillbirth, fetal loss, or early neonatal death. In terms of the fetus, if they're premature, if they're post-mature, if they've got congenital abnormalities, or if they are in multiple gestation, a lot of these things are much more likely. placenta previa and other placental anomalies, and oligohydramnios or polyhydramnios, which means too little or too much amniotic fluid in the sac. Also, in terms of if they're a transverse or breech presentation, if they've got chorioamnionitis, which is infection of the amniotic fluid, foul-smelling or meconium-stained amniotic fluid, antenatal asphyxia, potentially because of the positioning or lengthy delivery or something like that, or they're asphyxiated by the umbilical cord, or instrumental delivery, which, to be honest, is probably not the cause of many of these problems, but because a more distressed baby with other problems is more likely to be delivered with instrumentation, it kind of confounds a bit, I think. So now, hopefully, we've delivered the baby, and we've now transitioned with that first breath. As you'll learn if you do a Caesar list, which is a really good thing to do both as on your OBS placement and on your PEDS placement. As soon as you hear that baby cry for the first time, you know everything's probably going to be okay. Really, the ones you worry about are the silent ones or the floppy ones, but as soon as they're crying, it's usually a really good sign. So the first step is to dry the infant, clear their airway, and provide them with warmth, be that a heat lamp or blankets and a mother's skin. And this is the key assessment that you make when you see a newborn. The first question is the infant full term? Because that already makes them at a much lower risk of any of these complications I'm going to talk about. The second question is, does the infant have good muscle tone? Because a floppy baby is a baby to worry about, but a baby that's got good tone, in most cases, is going to be fine, certainly in the short term. And is the infant crying, or if they're not crying, are they breathing fine? Because if the answer is yes to all three, then you want to straight away prioritise that skin-to-skin contact and mother-infant bonding, which will hopefully also help with breastfeeding and, help in terms of the general perception that I guess many women want to have a sort of as natural birth as possible, and so intervening as little as you can. If you're satisfied that the newborn sort of meets those three questions, then it's often pretty safe in the short term to let them, the family bond. So how do we assess a neonate? We use what's called the APGAR score, which is an acronym you can see down here. And you will, once you've done this a couple of times, you'll see it become sort of second nature. That most babies, it's very common to have an APGAR of 9 or also 10, but 9 is also totally normal. And it's only if you sort of have below 7 or below 4, if you're sort of really worried, that you start to worry. And you evaluate the APGAR after 1 minute and then every 5 minutes until things are looking rosy. Interestingly, if you have a low APGAR at 5 minutes, that doesn't have a good correlation to having poor neurological development long term. So there's no point stressing out a huge amount after 5 minutes. You've just got to make sure you resuscitate the baby okay, and then they should most likely, 90% of the time, be fine, even if at 5 minutes they've got a poor APGAR. So what is an APGAR? Do they look white? Do they look blue? Do they look pink? Often, this is often really beautiful. Often the baby will come out looking quite blue, and you can see this line almost go up them as the perfusion comes through them, as they, just after they take that first breath. But often they're blue for a few minutes first. Do they have a pulse? And over 100 is a good sign, as you'll learn if you're doing CTG in obstetrics. A faster fetal heart rate is generally a good sign. Lower, we talk often in an adult tachycardia is a bad sign, and bradycardia is less of a worry. In fetus, it's probably the other way around. It's better to have a faster heart rate than a slower one. How irritable are they? If you inflict some a sternal rub or something on them, how do they respond? Are they irritable if they're crying? They usually get a 2 straight away for that. What's their tone like? And how's their breathing? So yeah, once you've done it a few times, it'll be second nature, but that's the approach we take to assessing the newborn. All I want to say about sort of the vital signs is that they're different to adults, and it's worth, when you're on PEDS, probably learning what the differences are. So don't just treat them like little adults, because they've got sort of very different vital signs. And I don't need to run you through the numbers right now, but the other important things to consider are what medications and what other drugs was the mother taking, and how could that be affecting the neonate, not just as a fetus, but also now as a neonate, because there's often some of whatever it was left in the serum. Sepsis can present as hyper or hypothermia, so watch out for that. and tachypnea, which in adults is an incredibly important sign, underestimated of how important it is in adults, but in kids is also a hugely important sign, and it can be indicative of respiratory or cardiac issues. So that's important to watch out for. So slightly different approach to vital signs. Important to think about how cyanotic they look, but otherwise kind of a similar idea in terms of how we approach vital signs of an adult, just slightly different parameters. So assuming the neonate doesn't need resuscitation, we'll keep them warm, we'll give them vitamin K, as I mentioned, we'll give them their Hep B vaccination, we'll care for their umbilical cord, we'll monitor their bilirubin and their sugars, and we'll give them a top-to-toe examination, which I'll go through in a second. So it's only a few things to remember, sort of 3 or 4 things, but it's worth learning and worth practicing when you do either a normal, either just delivery suite or a Caesar list. So we screen for, well, there are 3 types. We screen for metabolic conditions, which is about 25, 26 different conditions. The one that you should know about is called phenylketonuria, and also congenital hypothyroidism and cystic fibrosis. And the reason I put remember criteria for a good screening test is that the reason that we pick these conditions to screen for, as well as the 25 others included in metabolic conditions, is that they're all conditions where intervening early will make a huge difference to the prognosis of the child. So CF, if we can pick that up early on through the sweat test or DNA analysis, but the screening is the immunoreactive trypsinogen. It's important to know that one. It hypothetically could come up on the exam. And the other important thing to remember is that a screening test is a screening test, and that's why you then need to do a diagnostic test even if the screening test is positive. So you can see even congenital hypothyroidism is not that common, but obviously a very easy thing to fix and makes a big difference to the baby's development, especially that of the brain. Phenylketonuria is just an autosomal recessive condition where you can't metabolize phenylalanine, one of your amino acids, and what it means is that you get phenylalanine buildup, and that causes toxicity of various organs. Very easy to treat as well. You just have a low phenylalanine. I say very easy. It's a simple treatment. It might not be very easy for the patient to not eat foods with phenylalanine in them for their whole life, but it's a simple treatment. So you get your Hep B and vitamin K, even though vitamin K is not technically a vaccination at birth. You then get DTP, Hep B, polio, Hib, pneumococcal and rotavirus at 2, 4 and 6 months. I'm going quickly because you just need to learn this. There's no explaining to do. And the up-to-date link for the Australian immunisation schedules at the bottom of that slide, which, by the way, I will give to Dinesh. So you don't have to worry about copying things furiously because you get the slides. So examine the... so in terms of how do we examine the newborn, the most important things to think about when examining the newborn are I can't be slack about anything. I need to really do a top-to-toe examination because no one's ever seen this. No one's ever examined this baby before. And so if I miss something, then someone might never look for 15 years. If, for example, if I don't auscultate carefully and there happens to be a murmur there are many murmurs there are certainly some murmurs that might not get discovered for 15 years. So it's really important to be thorough with your examination. 2 of the kind of things that I would look for on general examination, because they're very common, you can't really see them very well, can you? Can I change the lighting? Room settings. Movie. Mongolian blue spots on the left, and it was called a hemangioma, which is a benign tumour of a blood vessel. It's also a hemangioma, but this is the kind of textbook one down here, but they often present like that as well. So it's important to look for those so that you can sort of watch. Often the hemangiomas, for example, will self-resolve. Often the Mongolian blue spots will change or resolve, but it's important to note because hemangiomas, for example, can actually get worse. And so you need to have peds follow up to monitor the hemangioma if you see one. And then obviously we're looking for spontaneous movement. Does the kid look well? Just like any general examination. We can probably go back to not sleepy mode because I know how easily you'll fall asleep otherwise. important thing with any PEDS examination is you need to chart their height, weight, growth, and a head circumference. And at this point, we would call it length and weight rather than height because the baby can't stand up yet, so we measure it lying down. But they're all very important things, and head circumference particularly is important, more as a trend, but also initially because it's going to alert us to many other conditions as the baby's growing up. The anterior fontanelle, which won't have closed yet, is actually a really good diagnostic tool, I guess, in that if it's bulging, that could be representative of a raised intracranial pressure. If it's sunken, that could be representative of dehydration. And if it's fused, then that also can present problems as the child grows. Looking at the face, looking for congenital diseases, which we say every time we say any examination, but in this case it's actually really important because, as I said, no one's looked for the congenital abnormalities first, so you really do need to be thinking about this. And this is one example. This is fetal alcohol syndrome. And the reason I put this in as an example is because certainly in PEDS land you'll get quizzed as to what they look like. And whilst, you know, if I said to you, what does Down syndrome look like, what does a person with Down syndrome look like, you probably have a good idea what that looks like in your head. It's actually worth practicing describing, you know, epicanthal folds, a thin upper lip, a smooth philtrum, as, in this case, fetal alcohol syndrome, but being able to use actual words to describe what someone with a certain condition looks like, because I know certainly for me, I knew what someone with that syndrome looked like, but I had to learn in 4th year how to actually describe it. Looking for facial palsy, looking for cleft lip or cleft palate. You check for the suckling and rooting reflex. So suckling is pretty obvious. You just put your pinky in their mouth and they suck on it. And the rooting reflex is if you just put something, you just stimulate the edge of their mouth, then they actually move towards it because that's like it's sort of how they find the nipple. So you put anything in contact with their cheek and they should just sort of wiggle their way over and start sucking on it. And these reflexes are quite adorable, which they should have. And you know, the absence of those things is important because then, you know, the mother doesn't feel like they're being incompetent. It's actually the kid doesn't have the reflex if they're struggling with breastfeeding. The red light reflex, you just shine a torch and you should be able to see a little red over the lens is the word I was looking for. You look for strabismus, so are the eyes following, are the eyes moving in symmetry, do they have ptosis, do they have anything anatomically that's wrong with their eyes, and do their ears look abnormal, does the cartilage feel normal, and often, I've read this in many a textbook that we test for hearing loss. I can't say I saw anyone test for hearing loss, maybe that's done through, I think people might get referred to audiology. Anyway, it's certainly, in textbook land, it's certainly done, and I think it might be done through an audiologist, but I didn't see a paediatrician examine for it, but it's worth saying and thinking about. In terms of their breathing, you're looking to see, is there any grunting? Is there any nasal flaring? And the reason I mention these signs is just because they're different presentations of, you know, respiratory distress. In an adult, you might have, you might ask someone, are you short of breath? Or you might see someone who has a stridor or a wheeze. In a neonate, that's going to be potentially grunting or nasal flaring or intercostal or subcostal retraction. So really you're sort of observing for these things and looking for these things specifically. If you hear a soft systolic murmur with no associated signs, then that's sort of quite a common thing, sort of an incidental murmur, a flow murmur that kind of goes away as the kid grows older. Check the anal patency for atresia to make sure that it is patent and that there are no fistulas. Check the genitalia. Very important to see if there's commonly vaginal discharge or bleeding, and that's because the mother's progesterone is no longer in the system, and as I said, the hormones take a while to right themselves in the neonate, so there's no progesterone, so that bleeding is quite common. Check that the scrotum is pendulous, which means hanging, and well rugated, which means sort of wrinkly, and that both the testes are descended, so you need to feel for both the testes. And you also need to check for the placement of the urethra, because if the urethra is sort of halfway down or not in the right spot on the penis, that's called a hypospadia. Also hernias and hydroceles. All these things that in an adult you need an indication to check for, you need to check for in every neonate, and that's kind of what I'm trying to drum home. Hips, you do what's called the Ortolani-Barlow test. It's easier, I had a look for some videos, but it's really easy if you just see someone do it, which you should do, and they're to check for hip dysplasia, developmental dysplasia of the hip, and you just listen for, you push the hips in and rotate them and listen for, abduct them and listen for clicks, clunks is what you're listening for. But you'll need to try it on a neonate. Checking the legs are symmetrical, equal in length. The arms, that they have a normal grasp reflex, so you put your pinky in there, or you try and put your pinky in their palm and they should grab onto it as a reflex. And you can check their pulses, femorally and brachially. Symmetrical creases of the thigh and buttocks, check for spina bifida. And the Moro reflex, I thought we'd have a little, hopefully the video works, we'll see how we go. Just because the Moro reflex has to be the best reflex of all time, I think. Oh, we're not up. What's happened? How do I... am I going to stuff everything up, Dinesh? If I go pause, if I just go end show... Still loading anyway. Okay, it's not going to work. Pity. Moro reflex is fun. You'll see it in real life. So a Moro reflex... the Moro reflex, all you do is you get the neonate, you support them with your hand, tuck their arms in, and you drop them back suddenly, and they kind of flail out like this. It's just a brilliant reflex. And it's a good sign of tone in a healthy neonate. But it's just really a fun thing. So just a reminder of the incidences of the different congenital abnormalities you're checking for in examination. I think I've mentioned most of them. The exception will be congenital heart disease, which I think you're getting a different lecture on in a few weeks' time, so I haven't emphasised that. It's important to learn the sequelae of Down syndrome, especially that they can get Hirschsprungs, they can get AVSDs, atrial and ventricular septal defects. That's a very common, well, not very common. If you have an AVSD, commonly you will also have Down syndrome. And another one that kids with Down syndrome get is called duodenal atresia, where you get this kind of sort of congenital narrowing or complete blockage of the duodenum here, and you get which is called the double bubble sign, and that's just because you get a huge build-up of gas in the stomach, and therefore you get the bubble of gas in there, and they can often cause polyhydramnios because they're not circulating amniotic fluid in utero. People with Down syndrome also often get celiac disease, and they often have issues with feeding as well. So it's just important, again, common OSCE topic. There's not much sort of I need to teach you about that other than learn it, because you need to sort of be able to riddle them off as 1, 2, 3, 4, 5, kind of, here we go. In terms of neonatal resuscitation, it's really just like variations on the theme of Doctors ABC. So I'm reminding you that we start with those 3 questions, because that is really about how we determine how suspicious and how worried we are about the baby. Is the infant full term? Does the infant have good muscle tone? Is the infant breathing or crying? Okay, then we go on to look at the temperature. We use warm towels and humidity-crib. We stimulate the baby, which usually just means cleaning off whatever gunk and amniotic fluid they're in. But also that sort of stimulation actually helps the baby realise that, oh yeah, we're out of the uterus, we've got to kick into action. So stimulation actually has therapeutic benefit as well. Secure the airway, so positioning of the head and positioning of the neonate, and suction if there's meconium present or you're concerned if the neonate's coughing or choking or gargling or something and not able to breathe, you can use suction. If you've secured the airway but they don't seem to be breathing, we use what's called positive pressure ventilation via face mask, or as a typo, and we start with room air, measure the sats, and then you just titrate the oxygen to get their saturations right. Usually if you restore the ventilation, the circulation should right itself. But if that's not the case, then after about 30 seconds of positive pressure ventilation, we can start chest compressions. As you can see, it's kind of like variation on adult theme. And then we give IV adrenaline through the umbilical vein to get the heart going if we're still below 60. So let's have a 2-minute break to stretch your legs and just refresh, because it is 6:45. And then we're going to jump into sort of prematurity and some of the actual pathology. You can have a go at the questions. Like, okay. I'll ask someone who's on peds. Okay, have a go at the questions now. Just have a go at the questions. When you... Okay. So I appreciate at this point in the year you probably, or you may be superstars, but at this point of the year I certainly would have no idea about these questions. But I feel like if I tell you the answers and then do the questions, they're even more pointless than if I do the questions and then tell you the answers. So that's why I'm doing it in this order. I have actually thought about it, but I thought we'd do some. So a full-term baby boy is born by elective caesarean section. He develops signs of respiratory distress at 30 minutes of age. I have told you the answer to this one, so you should know it. You nodded. What's the answer? Not in this case. It's transient tachypnea of the newborn, which is B. And that's the difference here is that transient tachypnea of the newborn is when they have retained fluid from the amniotic fluid, and that's why they've got tachypnea, and that usually is self-resolving or resolving with a bit of oxygen, and the risk factor for that is caesarean section because they haven't squeezed out the amniotic fluid or they don't have the benefit. It's actually also quite hormonal. Like, we get taught that it's about the squeezing of the vaginal birth, but it's also to do with the hormones and the sequence in which the hormones are released in a normal vaginal birth versus a caesarean. So there are multiple reasons why the caesarean is a risk factor. Whereas respiratory distress syndrome, the risk factor is prematurity, and it's a lack of surfactant, meaning that the baby can't expand its lungs. I'll go over that again in a second. But yeah, thanks for having a go, or I dobbed you in. Number 2, a full-term baby girl developed central cyanosis a few hours after birth. She was treated with prostaglandin therapy. I haven't covered this, so I don't, but does anyone who's doing peds know the answer? Yeah. Do you want to explain, or do you want me to explain? Do you want to explain? Thanks, that was fantastic. So the important thing is that prostaglandins are good at keeping the ductus arteriosus open. And what happens is normally in a neonate you don't have prostaglandins that your mum had, and so without the prostaglandins the PDA shuts. And so the thing to remember is that whenever we want to keep something open we use prostaglandins, and as you'll remember from first year pharmacology, what inhibits prostaglandins? NSAIDs like indomethacin or even ibuprofen, and that's what we use if we want to shut one of these, a PDA or a paedium foramen ovale or something. If we want to shut it, then we use indomethacin because that's a prostaglandin inhibitor. If we want to keep things open, then we use the prostaglandins. That was what the interesting bit of that question was. Number 3, a term newborn develops hyperirritability, gastrointestinal dysfunction, sneezing and exaggerated reflexes at 72 hours of age. That's just a bit of a fun one. Which is F, neonatal abstinence syndrome, just to get you thinking a bit outside the box and thinking about why is the neonate responding in this way, and to remind you of the link between what's in the maternal circulation and the fetal circulation. 4, a baby boy was stillborn at 37 weeks gestation. He had rocker bottom foot and overlapping fingers, and that's just a buzzword question. It's K, trisomy 18. So 8% of births are premature, or sorry, preterm labour is what we're talking about on the maternal side, and prematurity is what we're talking about on the baby side. So I've used both words there. And most of those that occur between 32 and 36 weeks have absolutely excellent prognosis, and I imagine many of you guys are or were preemie babies, and that's made no difference. But in some cases it does, and that's what we need to be wary of. I guess all those risk factors are pretty logical. Think about maternal, again, maternal and fetal risk factors. Maternal, if the cervix is compromised or weak, if there's an infection, if there's a stress, if there are multiple pregnancies, all those things make up, there's just less space there for 2 fetuses than if it's just one. If you have preterm premature rupture of membranes, that's PPROM, then you usually give oral erythromycin to prevent coronary amnionitis because that then has its own risk factors. And you can also give what are called tocolytics, although the evidence for them is not very good. And that is if someone who's 32 or 34 weeks or whatever starts labouring, you want to try and slow them down enough to do 3 things. The first is to be able to give corticosteroids, and that is to help mature the lungs. That has quite a good effect at maturing the lungs, and that's to prevent respiratory distress syndrome. You consider giving antibiotics depending on the presentation and the situation, but I guess probably most importantly of those 3 is that you want to get them, if they're giving birth at 32 weeks, it's much better to do that in a tertiary centre where there's going to be good care for the infant. And I suppose the mum, because there might be a sinister reason that she's going into labour, but especially the infant, and so that's why you might use something like nifedipine or terbutaline to prolong the labour. And yeah, it's not really, it's for those reasons. So another good kind of OSCE station is prematurity. And I've sort of tried to go through logically what the pathologies are and then how you treat them or how you need to think about them. So I mentioned respiratory distress syndrome, which is due to a lack of surfactant. You want to get their SATs and you use oxygen, often CPAP, potentially give them surfactant, and you can also use theophylline to try and correct the lack of surfactant. Apnea is just where they're not breathing enough, they stop breathing. It's like you've learnt about obstructive sleep apnea. This is just apnea because they're not breathing, not because they're obstructed. And the fun treatment for that is caffeine. So that's another. See, paediatrics is full of fun, isn't it? Mororeflex, caffeine, oh, it's just joy. I absolutely love paediatrics. Jaundice is very common, and I'll go over this, but the things to think about, also the reason that it's so common is because of hepatic immaturity and the fact that your red blood cells as a neonate have a shorter half-life, or as a fetus have a shorter half-life, and so there's sort of more hemolysis happening than there would be in you or me. And that's why you get so much, I guess, what's called physiological jaundice or breast milk jaundice, sort of benign jaundice conditions. I guess the reason I'm going to go over jaundice specifically is because it can be benign, but it also can be a bit more sinister. But in many of those cases, we use phototherapy, so like a blue light, to help conjugate and get rid of the bilirubin. Talked about thermoregulation. Importantly with nutrition is that the suckling and swallowing reflexes only sort of develop between 34 and 36 weeks. And so if you've got a 34 or 33-week-old baby, then, or they had that gestation, then they might not suckle. And so you can't actually get them to feed off the breast. I mean, also the mother might not be producing enough milk. So you can have problems on both sides. And so you might need to supplement with a nasogastric tube. But you still want to progress to breast milk as fast as you can. The other thing to remember is those last 8 weeks in the womb are, like most, as you'll learn when you do obstetrics, most things have sorted out by 32 weeks, and that's why so many preemie babies survive very well. But there's still a lot of growing that has to happen in those last 8 weeks, and so they have a high nutritional requirement. So it's really important to look after their nutrition. So patent ductus arteriosus is one of the most common cardiac complaints of prematurity, and as I mentioned, we use indomethacin we can use indomethacin to close that if it's patent. It's kind of the opposite situation to what we were talking about before. They can have a bit decreased tone, but that usually rectifies if it's not something sinister. And they lose lots of fluid because they have thin skin. They have decreased glycogen stores because they haven't had as much time to build up the stores, and they have increased glucose requirements because they've got all that growing to do, so they can get hypoglycemic. Again, it's interesting to think about why are these things happening, not just, it's a small baby, therefore I should be worried. A bit more interesting than that. And the kidneys aren't quite mature enough yet, so you can sometimes get hypocalcemia, and they're also at high risk of infection. Their iron metabolism is often not quite right, so they can get anemic. They can get hernias, undescended testes, and they often, or a widely separated labia majora in girls, but they often self-correct, but you need to monitor them. They're at higher risk of intracranial hemorrhage, and that's associated with cerebral palsy, and they can get osteopenia as well. That's again because you've got impaired mineralization of bone because you've got deficient vitamin D, but normal resorption, and so you can get osteopenia. And then NEC, or necrotizing enterocolitis, is a rare inflammatory process that you will unlikely to see on your clinical placement, but you should know about because it's sort of rapid bowel necrosis of unknown etiology apart from the fact that it's associated with prematurity. And you can get bile stain vomit, you can get bloody stools, and you often have normal respiration. Sort of marker of something seriously wrong, but the cardiorespiratory stuff is under control. Longer term, interestingly, they often have delayed growth or decreased growth, but in the first 2 years of life, most premature babies will catch up. Some don't, but most do. You can get bronchopulmonary dysplasia or chronic lung disease because the lungs are underdeveloped, and that's one of the things we're trying to avoid, but with those corticosteroids if you have preterm labour. You can get visual impairment, hearing loss, cerebral palsy, which is often due to hypoxia, is what I was looking for. Again, developmental delay, a lot of it corrects itself. Only sort of 5 to 10% of preemies who have developmental delay actually have something seriously wrong with them. They can get retinopathy of prematurity, which is due to fibrous scarring, due to the arterial, or the what's the word I'm looking for, capillary supply, and that's mostly resolved spontaneously. And you can also, they're also at high risk of autoimmune diseases. Okay, so have another 2 minutes to have a go at these, just so that you're not falling asleep. Okay, these are hopefully a bit more, now you've got some idea of what's going on. Anyone have any idea about number one? You've got a 3-day-old baby who was born at 30 weeks gestation, who shows no signs of respiratory distress, but has recurrent pauses in his breathing that last for more than 20 seconds. Should be pretty obvious. J, apnea of prematurity, good. 2-week-old baby girl who was born prematurely at 28 weeks gestation becomes increasingly lethargic with marked feed intolerance on examination. That just means sort of distress while feeding and after feeding and not wanting to feed. Plus or minus vomiting. On examination, her abdomen is swollen and tender. Anyone? Yeah, H, necrotizing enterocolitis. And really the thing you've got to look out for there is sort of quite severe prematurity. This condition, number 3, this condition may be caused by the acute or chronic effects of oxygen toxicity on blood vessels. I just told you the answer to that, as is G, retinopathy of prematurity. 4, a baby boy is born at 26 weeks gestation. When he is 10 weeks old, he still requires nasal prongs oxygen. His X-ray shows a sponge-like appearance with areas of lung opacification. What? No, I'm just trying to find it. I know what the C, chronic lung disease. Again, it's just trying to get you to think about how is this presenting? Is this acute? He's 10 weeks old. It's not respiratory distress syndrome or transient tachypnea of the newborn. Trying to get you to sort of triage these respiratory complaints. I think all I haven't mentioned there, just because I've covered a bit of this already, is that on chest X-ray you often get this sort of what's known as a ground glass appearance. It kind of looks a bit like ground glass. That's sort of pathognomonic for respiratory distress syndrome, lack of surfactant. The other thing I haven't mentioned is they often get a grunt. That's quite a common thing. The most common cause of neonatal pneumonia or sepsis, which is usually from either the vaginal or the mother, but usually from the vaginal flora, and the most common is group B strep, so that's important to remember, but you can also get chlamydia, E. coli and listeria, and so you want to have good gram-positive and good gram-negative cover, so the sort of empirical neonatal pneumonia treatment is benzylpenicillin and gentamicin, and the risk factors make sense in that it's just prolonged exposure of the fetus to the vaginal flora, basically. Or, in the prematurity case, they have a weaker immune system. So 60% of TTN is benign and self-limiting. In fact, yeah, and it's really about not getting the alveolar fluid out of their lungs, and usually 25 to 30% of oxygen should lead to rapid improvement. Meconium aspiration is a diagnosis of exclusion, but you should have a high suspicion if there's meconium liquor, and they just get sort of hyperinflated, kind of barrel-shaped lungs like this, with this sort of streaking you can see here, kind of streaking everywhere. You can see there is still nice kind of air-inflated bits. It's not like, there's not the same as the ground glass, but you've got this streaking throughout the lungs. And that's, as I said, a diagnosis of exclusion. So now we're going to talk about neonatal jaundice. So we've got a baby girl born at 35 weeks gestation by caesarean section who develops jaundice on day 2 with a maximum bilirubin level of 200 millimoles per litre on day 3, which resolves by itself by day 7. So commit to an answer. As you might expect, given that it resolves by itself, that's physiological jaundice. That's just the typical picture of what physiological jaundice looks like. There's nothing there to make us worry that it's something more sincere, and the self-resolving is a very good reassuring factor. A baby boy, number 2, a baby boy is born by emergency caesarean section at 37 weeks gestation due to rising maternal anti-D titers and pleural effusion seen on the baby's antenatal scan. He is very edematous at delivery and the cord bilirubin level is 50 millimoles per litre. Should be obvious, and the reason I included the question is because you need to be able to get this question right even if the maternal anti-D titers was not in the stem of the question. Hopefully that's given it away and you've realised that it's C rhesus incompatibility, but I thought it's nice because you then can learn what else is associated with that other than just rising maternal anti-D titers. Number 3, a baby boy of Mediterranean origin is born at term by normal vaginal delivery after an uncomplicated pregnancy. What this has reminded me of is that it's really important whenever you see a neonate or think about a neonate that you take a good obstetric history, because that's actually going to give you much more idea about the risk factors of the neonate, because the neonate has no history to take. So that's something to think about. So in this case, we've got a normal vaginal delivery after an uncomplicated pregnancy, so we've already not got many real risk factors. Although they're Mediterranean origin, so we should think about thalassemia. I'm joking, that's just a EMQ joke, but you'll see why in a second. He is discharged home the following day after a normal baby check. He presents again at 14 days of age with severe hemolytic jaundice. So the giveaway in this question is the word hemolytic, which means you should think about G6PD deficiency, which is an enzyme deficiency. I'll go over it again in a second. But the important thing is that you need to be able to think about what causes of jaundice are hemolytic versus what causes of jaundice are not hemolytic and differentiate them that way. And also, when is the jaundice? And I've got a little table at the end which breaks it down by when the onset of the jaundice is, and that will help you differentiate the diagnoses. But I just want to point out those approaches to thinking about it. So the differentials for neonatal jaundice are common. It's very common. It's dependent on age. Jaundice in the first 24 hours, you should always think it's pathological. And if it's unconjugated, you should be thinking about these causes, which I'll go over again in a second. And it's unlikely, importantly, for thalassemia or sickle cell anemia to present in a newborn because they've got, so hemoglobinopathies are not so common because they should have much of their fetal hemoglobin. So you do, if you've got jaundice in the first 24 hours, you investigate the mum's and baby's blood group for obvious reasons. You check the baby's serum bilirubin, both total and unconjugated, again, because that helps you differentiate what the cause of the jaundice is. You do a Coombs test, which is a test to see if the cause is autoimmune. And you should commence phototherapy as empirical therapy if the bilirubin's below 150 micromoles per litre. The next sort of level, there's not much else you can do apart from phototherapy other than an exchange transfusion if the jaundice is super severe. So a Coombs test is just to, if we suspect a hemolytic anemia, because a positive Coombs test indicates an immune mechanism is responsible, a negative suggests it's less likely to be immune. That's all you really need to know about a Coombs test. Physiological jaundice appears usually on days 2 to 4 in a normal term baby. The baby's well, passing normal coloured stools and urine. Again, stools and urine, just like in an adult, are a good indication of whether the jaundice is conjugated or unconjugated. And and the bilirubin levels aren't sky high. So 1/3 of term babies were visibly jaundiced. I'm proud to say I was a jaundiced baby. Yeah, okay, that's just the rates. Things to think about if you've got unconjugated bilirubinemia is like outside your typical areas. So hemolysis, infection, hypothyroidism. So look for meningitis. So biliary atresia, which is, you should be able to understand from the words, which is atresia of the biliary duct or other parts of the biliary system, lead to acholic stools, so grey stools, because they're not getting any of their bilirubin into the actual, their bile's not going into the duodenum. You can get neonatal hyperhepatitis, you can get a choledochal cyst, which is just a cyst obstructing the bile duct, or it can actually be a complication of TPN if you've given them TPN. So G6PD deficiency is an X-linked recessive condition, and is usually because you get an imbalance between how much jaundice, how much bilirubin you're producing and how much you're conjugating. So most are fine without treatment, but it's important because they can have other sort of side effects later on, and it's an important to discontinue whatever the agent, whatever usually a drug, but it can be something else, is actually causing the G6PD. Causing the jaundice, sorry. The G6PD is genetic, so that's the agent's not causing it. It's genetic, but it's the jaundice is caused by an agent. I mentioned biliary atresia, and breast milk jaundice is a diagnosis of exclusion with a well breastfeeding baby with persistent jaundice, and that's potentially because of the components of the breast milk, we think. Importantly, the reason we treat bilirubin, hyperbilirubinemia, jaundice, is that that bilirubin is a neurotoxic substance, and so you can get actually quite bad brain damage if you get what's called kernicterus. So if the bilirubin level gets too high, it can cross the blood-brain barrier and affect the brain. So it's kind of the reason that's there is because this is the primary reason that we need to treat the bilirubin itself. No, the jaundice, which is the same thing, hyperbilirubinemia. And that's the table I mentioned. It's just good to think about, as you can see, unconjugated versus conjugated in the first 24 hours. 24 hours to 14 days, you can see that's where physiological and breast milk jaundice both fit in, or prolonged jaundice also could be breast milk. But so obviously, because there are physiological causes from 24 hours onwards, it's really that first 24 hours that we worry about. So this is, I think, quite a good way of thinking. Not all the causes of jaundice, but the ones you need to think about. Good way of stratifying them. In terms of the floppy infant, this is sort of a typical, you might have a typical presentation of a floppy infant, and so maybe think about what differentials you'd have at this point. How they present on an examination. Well, they might have difficulty sitting, sort of pulling to sit. You pull the neonate up and see how their head comes along with them, whether they have head lag or whether their head comes with them. You can suspend the baby abdomen down in your hand and look at how they sit, and that will give you an idea of what their tone is like. You can hold the baby upright, and you also do a full neurological examination. But often it's very clear from the sort of, are they feeding, how do they look? When you see a floppy baby, you'll know. So importantly, you manage the nutrition because they probably can't suckle, and you manage the respiration because they're the two most important things to get right if the baby's tone's not good. So you can get benign neonatal hypotonia, but this is mostly seen in very premature babies who are basically neurologically underdeveloped. And that normalizes by itself. A common cause you need to think about is an infection, and the torch infections are the ones that we sort of worry about in mum, as you'll learn in obstetrics, which is toxoplasmosis, syphilis, varicella zoster, parvovirus, rubella, CMV, and herpes. the reason it's torch is because syphilis, varicella zoster, and parvovirus are other. So it's T-O-R-C-H. Sorry, I should have bolded that to make it clear. But they're the ones to worry about, and that's worth learning. And 60 to 80% of severe hypotonia is caused by one of these neurological conditions, either hypoxic ischemic encephalopathy, that's HIE, genetic abnormalities, or cerebral malformation. So that's why if we've got a floppy baby, we do tend to worry, because it can be caused by something a bit more sinister. And sometimes it's caused by peripheral cause, neuromuscular complaint. So these are some of the things that would make you worry about infection: vomiting, distension, drowsiness, floppiness, seizures, temperature instability, tender limb. I guess the thing that's really important to think about with infection is it can present any way you like in a neonate. And you really just have to have, even just an irritated neonate, you have to have a high suspicion for infection. And that's, I guess, what I want to emphasise. And so we often send off blood cultures and urine cultures and various other cultures in neonates because an infection can really present any way it likes. And that's again, the empirical treatment. So the sequelae of central hypotonia would be issues with consciousness or seizures, so abnormal brain function, dysmorphic features, muscle weakness, reflexes are often normal or hyperactive. Think about how you differentiate central from peripheral signs. It's just the same as in an adult in that regard. It's tight hand fisting, so basically it can be a sign of cerebral dysfunction. And you often need a wide range of investigations because there's a long list of possible causes of that. And that's some of the causes. HIE is important because it can sort of be the cause of cerebral palsy and is kind of quite a broad syndrome that's worth learning about, basically due to intrapartum hypoxia. Which leads to encephalopathy, which can have sort of anything from no to quite severe implications, and that's the one which you often get lawsuits about because, you know, the baby was hypoxic and developed XYZ and the mum thinks it's because of the way it was delivered or something that happened in the actual delivery. If they have extreme hypotonia and tongue fasciculations, then you need to think about a congenital disease called spinal muscular atrophy. Down syndrome is a common genetic cause of hypotonia. As you can see, this is kind of just a long list, which is why I'm not spending a huge amount of time on it because, you can read things. Prader-Willi, you should recognise the name because the sort of pathognomonic buzzword is the insatiable hunger that the kids get. Obviously, the neonate can't really tell you that it's got insatiable hunger, so often they present with hypotonia, hypogonadism, difficulty feeding, often normal respiratory function because that's helpful to distinguish from the differentials. And over time, usually the tone normalises and instead you get insatiable hunger, obesity, and often mental retardation, often developmental delay. So yeah, that's an interesting one to think about how it presents earlier. Causes of peripheral hypotonia can be lower motor neuron disease, such as like spinal muscular atrophy I mentioned. Could be demyelinating neuropathies, myasthenia. All this stuff is each one of these diseases is quite rare, but because they kind of present or can present similarly, you need to. This is why it's an important topic, I guess, rather than each one of these things is rare and unlikely in their own right to come up, but it's important to have an idea that there are many causes. So we do a serum CK to get an idea of what their muscular function is like and muscular, what's what I'm looking for, homeostasis. Analyse the CSF, and then more complicated neurological investigations. If you get progressive weakness, the thing to think about is a muscular dystrophy, and that, again, you won't know it's progressive if you haven't done a good neonatal examination and seen how it's progressed, but that's got a pretty bad prognosis, so that's something that you think about if you've got progressive weakness. So I mentioned that an upset infant, you need to think about, are they septic, are they uroseptic specifically, because, you know, they're probably upset for a reason. Things to think about in terms of febrile seizures are that if you have one febrile seizure, you're at no increased risk of having seizures or a seizure disorder later in life. But if you have multiple febrile seizures, then we do, and plenty of kids have them, but that then raises our suspicion and raises your risk of having a seizure disorder. And failure to thrive isn't really a neonatal condition, but I thought I'd mention it because it probably might not fit under any of the other revision lectures. And that's just thinking about, you know, this sort of a presentation you don't really get in adults, which is just, is the kid growing? Is the kid developing? Is the kid meeting their milestones? And I guess you won't pick this up if you don't measure those milestones and assess the kid as they're, you know, and as they're an neonate, and then as they're an infant, and as they grow, you won't be able to tell if they're failing to thrive unless you measure those things. So I hope that was a little useful. I appreciate a lot of you will have sort of heard that and thought, oh, I didn't really understand, or I didn't know those words, but hopefully maybe when you start PEDS you'll recognise some stuff, and maybe it will be useful to go over later in the year, especially some of those lists and sort of OSCE things I mentioned. I wanted to mention a couple of things that are coming up in case they're of interest to you. I'm with a team, we're running a conference on May the 7th called Monash Future Thinkers, which is about what Australia will look like in 2050, not just in healthcare and biomedicine, but sort of across the board. And if that's something that interests you, then put the day down. Give Monash Med Orchestra a plug. We're playing Beethoven 5 on May the 15th, and you should be playing in it, mister. Anyway, I'll come and hunt you down afterwards. Yes, you know who I'm pointing at. But we can have that conversation another time. If you're interested in doing a BMed Sci or research, we're running a conference hopefully on July 16th about life as a clinician scientist with sort of tips on how to write papers, how to approach research. So if you're thinking about doing BMed Sci, that could be something to come along to, and then hopefully some more music on July 30th. So hopefully that was useful, and head off into the evening fun and enjoy fourth year. Thanks.